Okay, this is going to be the facial trauma lecture for the 2014 paramedic refresher for Trotwood Fire and Rescue. This will be the lecture that covers January 25th, 2014. So basically, for mortality, it says that primarily associated with brain and spine injury. With that being said, people typically don't die of, orbital fractures. They don't die of maxillofacial fractures. They don't die of mandible fractures. They don't die of broken noses. What they die from is the associated injuries. In other words, things that are, the brain injury, the spine injury. If it was enough force to, cause a maxillofacial fracture, a mandible fracture, or orbital fracture, then, more than likely they probably have some kind of a brain injury or they have a spinal cord injury. So that's usually what the people end up dying from, and not necessarily the primary injury. And then severe facial fractures may interfere with the airway and breathing. We need to make sure that we are aware of that. Lying people down. We always talk about people that can't hold their own secretions, and we make sure that we give them a Yonkers suction catheter so they can suck stuff out of their mouth or their nose to help them breathe. That's not always possible if you have somebody that's unconscious or you get somebody that's just not capable of doing that. So what you have to be aware of is that if they have a facial fracture and they're bleeding significantly, whether it be from like a sinus fracture or it's a mandible fracture, maxilla biting their tongue, whatever, that you may have to roll them up on their side, or you may have to have somebody assigned to just suction out saliva and blood so they end up not choking on it. And then a couple, comorbidities or morbidities, disability concerns. So people that are worried about, not being able to talk. Their jaw is wired shut because they've broken their jaw. Not being able to breathe out of their nose, and then with that, there's cosmetic concerns. You get the younger generation that are more concerned about their looks and what other people are going to think of them. So that in turn will cause anxiety, causes stress, which can make them sicker. So these are just some things you have to think about. So maxillofacial trauma, some of the causes we know it would be motor vehicle collisions, home accidents, falls, trips, athletic injuries, animal bites, violence, industrial accidents. Some soft tissue things, so lacerations, abrasions, avulsions. Remember that maxillofacial trauma in itself, just facial trauma, faces bleed, scalps bleed pretty bad. And the adult population, we need to worry about geriatrics. And the pediatric population, we have to worry about the infants. Those two, so the geriatric and the infants. Geriatrics just can't handle the blood loss. And if they're on Coumadin or any other kind of blood thinners, we have to be very, very cognizant of that. And then for the pediatric population, it does not take much for a baby to bleed out from just a simple facial laceration or a head laceration. So the vascular area is supplied by the internal and external carotids. Seldom life-threatening unless it's in the airway. And consider the spinal precautions, having suction available and control the conscious patients, and then control bleeding. Basically, it's everything that we just talked about before, except for the controlling bleeding. But we do need to worry about controlling bleeding. And once again, in those two populations, the infants, and the pediatric infant, and then the geriatric population. A little anatomy and physiology. Remember that there's a temporal artery, the mandibular artery, and the maxillary artery. And then for the nerves, it's trigeminal, the cranial nerve, the facial cranial nerve. So I will stop the lecture for a second, and then when it restarts, I'll have a picture of all of the temporal artery, mandibular artery, and the maxillary artery. Alright, so here's a picture of the arteries. You can see the facial artery, and run right along where the teeth would be there. Maxillary artery, ophthalmic artery, superficial, internal carotid, under orbital, traverse, the angular artery, zygomaticofacial, supratrochlear, the supraorbital, the frontal branch. So once again, it's very, very vascular. So these are the reason why for us, we need to make sure we control the bleeding from a facial laceration, because it doesn't take long for somebody to bleed out if we don't stop it. All right, we talked a little bit about the nerves, the trigeminal and then the facial nerve. Remember that 7th cranial nerve. That's, not only is it important for, trauma like maxillofacial trauma, but also when we start talking about Bell's palsy, that basically it's an inflammation of that 7th cranial nerve, and that's why people end up having the Bell's palsy. Right, so the bones, just to review, we get the nasal bone, the zygoma or the zygomatic arch, the maxilla, and then the mandible. So we know that the mandible is the lower jaw, and then the maxilla is the upper portion, and I will show you a picture of that. Okay, so as you can see, there's a occipital bone, parietal, frontal, temporal. The mandible, maxilla, zygomatic, nasal bone, ethmoid, and sphenoid. Alright, so I think we probably pretty much covered all the nasal, zygoma, zygomatic arch, the maxilla, and the mandible. Alright, this is fractures of the mandible, maxilla, nasal bone, zygoma, and rarely the frontal bone. That's the definition of facial fractures, and that's usually where we're going to see it at. So some of the signs and symptoms, we're going to have pain, swelling, deep lacerations, limited ocular movement, facial asymmetry, crepitus, deviated nasal septum, bleeding, depression, palpation, macular occlusion, blurred vision, diplopia, broken or missing teeth. So bottom line, they're probably going to have pain upon palpation. We need to worry about deep lacerations once again, not only because of the arteries, but also because there may be some underlying problem. That limited ocular movement, so their eye may be deviated one way or the other because of the broken, the zygomatic arch. Facial asymmetry, we need to worry about that. The deviated nasal septum, something we definitely need to worry about from a breathing standpoint. And the blurred vision or diplopia or double vision, and the broken or missing teeth. So things we need to worry about with this is, airway, breathing. That's the most important thing. And then also any kind of pressure that we may be putting on them. And remember that if they do have a facial fracture, they have the possibility of having an underlying brain or spinal cord injury, and we need to be very aware of that. Alright, so mandibular fractures, they have numbness, inability to open or close their mouth, excessive salivation, and macular occlusion. Anterior dislocations, this may be caused by extensive dental work or yawning, and condylar heads move forward and muscle spasm. I've seen that a couple times, some people that have actually yawned. I've never seen it from a trauma, but I've definitely seen it from people that were yawning and just had a weakening. So, right, LeFort fractures. I think I'm not sure if they still do it in paramedic school, but I'm sure they still, when I went through, we learned about all the different LeFort fractures. Remember, it's a specially named facial fracture. Usually requires significant forces, especially for the LeFort 2 and the 3. So LeFort 1, it's a maxillary fracture with a free-floating maxilla. LeFort 2 is maxilla, zygoma, floor of the orbit, and the nose, and the LeFort 3, which is the lower 2/3 of the face. So basically, if you can put your finger in their mouth, grab a hold of their nose, kind of like a bowling ball, and you could pick their face up, then it's a LeFort 3 fracture. So I'll stop the presentation, and I will show you a picture of LeFort 1, LeFort 2, and a LeFort 3 fracture. So LeFort 1 fracture is going to have, this is going to be LeFort 1 right here across the maxilla. LeFort 2, the zygomatic arch or the zygoma, and then when we and then when we go across here, this is where basically it's broken, and you can see it broken all through here. This is where if I put my finger basically in their nose and in their mouth, and I could pick their whole entire face up, then more likely they have a LeFort 3 fracture. So it's often associated with orbital fractures. Remember, there's a risk of serious airway compromise, bleeding, and edema. contraindication, NG tube or nasal tracheal intubation. So if you have the choice, and you do need to nasally tracheal intubate them, it's probably better to try to bag them if you can. If you've ever seen somebody with a LeFort 3 fracture, you've ever tried to bag somebody with a LeFort 3 fracture, it's very difficult, or just multiple facial fractures. Their face is just basically mush. So it's not that easy. Obviously, we're not doing NG tubes, but as I've said in prior presentations, that is currently in our protocol for the state, or the curriculum for the state. It's just not currently in our protocol for this region, but I definitely see that coming in the near future. So they present with edema, epistaxis, or a bloody nose, that numb upper teeth, unstable maxilla, cerebrospinal fluid, or rhinorrhea. So they just, that runny nose, and we need a test for the cerebrospinal fluid. We've got the, the halo test where we fold up a 2x2 or a 4x4 to dip the corner in, open it back up, and basically the cerebrospinal fluid will separate from the blood that is on the 2x2 or the 4x4. So it's unusual facial appearance. So they have like a donkey face, or like a lengthening pumpkin face from the edema, or any kind of nasal flattening. So we just need to be aware of that. So spinal motion restriction, definitely, because once again, if they don't die from the bleeding and the salivation and everything else, and they're not drowning from that, and we're able to suction them, they could have a underlying spinal fracture, and they more than likely do. So airway is most difficult, most critical priority. Definitely consider early intubation on these patients, because once you lose airway, it's very hard to regain it. And it says surgical airway may be the only alternative, but never the first contraindication, or consideration, I'm sorry. So this is those times where it is probably appropriate to go to Good Samaritan Hospital if you don't have their airway and they're bleeding profusely and you can't get them intubated. This is the time that you would stop at Good Sam. But if you're able to keep their airway, you're able to suction them, you're able to bag them, and they still, you still believe that they have facial fractures, LeFort fractures, it's okay to bypass Good Samaritan to go to Miami Valley, because of that reason right there. They're going to need surgical intervention and a trauma surgeon. And the trauma surgeon, that's where they're at, is at Miami Valley. So we suction and control their bleeding, and it's a critical trauma patient. I think it's a fairly famous picture, and most people have seen it. If you've never seen it, this is the NG tube. They floated up, trying to go in. Once they floated it up, went into the sinus, come back out, and you can see it's all wrapped up into their brain there, and it's actually up in their head because they had a facial fracture, and it went right through the fracture. So ear trauma. External injuries, remember lacerations, avulsions, amputations, frostbite. We always control the bleeding with direct pressure. Typically, once again, ear trauma it's not a life-threatening thing. However, they may have underlying conditions, so just always keep that in the back of your head. Internal injuries, so spontaneous rupture of the eardrum will usually heal spontaneously. Penetrating objects can be stabilized and not removed. Same thing we learned back in basic school. Don't ever try to remove an object unless it is literally interfering with your patient, patient care. But we try to do everything we can to avoid ever trying to remove anything. It says, removal may cause a deafness or facial paralysis, and then hearing loss could result of optic nerve damage and a basilar skull fracture. Just a little anatomy and physiology for you. The outer ear, or the pinna, the cartilage, and the little blood supply, external ear canal, mucous membrane secretes wax for protection, and then the middle ear separated from the external canal by the eardrum, and its delicate structure is needed for hearing. Okay, here's a picture of the ear diagram. So you can see the outer ear, the middle ear, and then the inner ear, and here are all the different parts. So you just match the number up to the actual structure within the ear. Alright, so ear injuries we need to worry about. Separation of the ear cartilage, so we treat that as an avulsion. We dress and bandage it. We consider disability and cosmetic concerns. And then bleed from the ear canal, we always cover with loose dressing only. We do not pack the ears. We pretty much don't pack any body part. trying to stop bleeding or any kind of fluid from leaking. Just cover it with a loose dressing only. Alright, so you can see the eye anatomy. When we're looking at all these different parts, you can match it up. So with the cornea, the lens, the iris, for us, it's very important for us to look at, obviously we're looking at the pupil itself, looking at the lens to make sure that it's not cloudy, making sure that there's no blood in it, making sure that the cornea is the way that it's supposed to be and actually is there. So some of the injuries that we could see from a penetrating standpoint, there's abrasions, and that can be for anything. Foreign bodies, so deep, superficial, or impaled. And then lacerations, any kind of deep or superficial. And then also lacerations to the eyelid. Lacerations to the eyelid could cause quite a bit of problems for the eye in general, and at a later time as well. For burns, we worry about flash burns, whether that be from somebody that's lighting a bonfire and it's not going up quick enough, or it's not going as fast as they want. They end up throwing gasoline or kerosene on it, and it comes back in their face, and we get flash burns. Or acid or alkali. Somebody that's changing their radiator, or they're taking the radiator cap off, and the fluid is not cooled down yet, and it bubbles out or boils out, and it ends up getting in their face and splashed in their face. So blunt, we have to worry about swelling, conjunctival hemorrhages, hemphea, ruptured globe, blowout fracture of the orbit, and then a retinal detachment. So, right, it talks about the blowout of the orbital fracture. It's usually a result of a direct blow to the eye. Things that we're going to see would be a flatness or a numbness, so the person has any kind of numbness, or they have a flatness. Bloody nose or epistaxis, same thing. Altered vision, periorbital swelling, so just swelling around the eye. Diplopia or double vision, that impaired ocular movement, so they're just not able to move, or their eyes don't move like they're together. One eye moves, but the other one stays where it's at. So as for foreign bodies, typically it's sensation of something in their eye. They have excessive tearing or burning. This could be like a corneal abrasion. A lot of times, somebody gets sand or dirt in their eye. They rub it, and rubbing it, they end up getting a corneal abrasion. So they inspect the inner surface of the upper lid as well as the sclera. Make sure that it's okay to flip up their eyelid. A trick that I learned a long time ago is taking the top eyelid, and basically pulling it over top of the bottom eyelid, and it makes your eye tear up, and a lot of times doing that will actually flush whatever's in the eye out. And then it says flush with copious normal saline away from the opposite eye. I hope everybody knows the trick. If they don't, it's taking a 1,000 cc bag of saline, putting a nasal cannula, spiking it onto the bag, letting the fluid run through the nasal cannula, laying the nasal cannula basically across their nose, the bridge of their nose, and then it'll go into each eye and it flushes out. So it starts at the in the middle of their eye or the corner of their eye, and it actually will flush everything out laterally. So corneal abrasion is caused by a foreign body objects, eye rubbing, contact lenses. They'll have pain, feeling something in their eye, photophobia, or just that light sensitivity, tearing, decreased visual acuity. So we irrigate them, and we make sure we patch both eyes. It's the same thing that we did back at basic school, patching the both eyes, because if one eye moves, we know the other eye moves. So we want to make sure that we don't want either eye moving. And it says it usually heals in about 24 to 48 hours if it's not infected or toxic from the antibiotics. Right, so other globe injuries that we need to worry about: contusions, lacerations, the emphysema, globe or sclera rupture, the loss of visual acuity, blood in the anterior chamber, dilation or constriction of the pupil, of the pupil, pain, soft eye, pupil irregularity. And then remember, there may be some kind of an underlying problem, so we always consider C-spine precautions due to forces required for the injury. No pressure to the globe for the dressing, cover both eyes, and avoid activities that increase intraocular pressure. Activities that would increase intraocular pressure. So if somebody does have a global injury, so basically making their heart rate go up, their blood pressure go up, which is going to, in turn, it's going to increase the pressure inside the eye. Mouth injuries are usually a result of motor vehicle collisions, blunt injury of the mouth or the chin, and penetrating injury due to gunshot wounds, lacerations, or punctures. Just a little A&P. So remember, the tongue is obviously there. The masseter muscles. For the bones, we got the mandible, maxilla, the hyoid, and the palate, and the teeth. So remember, the tongue could become an obstruction, teeth become an obstruction, the mandible or the maxilla being broken, and you lay them flat, and then they're not able to compensate for that. That could become an obstruction. So primary concerns for us is obviously airway compromise, any kind of foreign body airway obstruction, and then any impaled objects. We make sure that we suction them as needed. Once again, if they're conscious, it's okay to give that patient the Yonkers. A lot of times they will know what to do with it. And if they're unconscious and they're not able to tolerate or they're not able to follow commands, it's very, very good, and it's a good idea to always make sure you take somebody with you so they can suction out the person's mouth as needed to make sure that they don't have fluids, whether it be blood or teeth or some other kind of object in the back of their throat. And we stabilize any kind of impaled objects, and we collect the tissue, so the tongue or the tooth, because remember, both of those can be reimplanted. So there's 32 teeth in a normal adult. They're associated with facial fractures. That's usually with dental fractures. We aspirate broken teeth, so you have to worry about that, getting the tooth stuck into the lung. So if the person has aspirated it, we have to be worried about that. So typically they'll end up doing x-rays at the hospital to make sure that there's nothing inside the lungs, or they end up having to CT the lungs. If all teeth can be replaced, so find them. Early hospital notification to find a dentist. For us, once again, dental trauma is through Miami Valley, so we make sure that we transport them to Miami Valley any kind of dental trauma. If it's less than 15 minutes, maybe ask to replace the tooth in socket. Don't rinse or scrub. It says it removes the periodontal membrane of the ligament. So if you find it, all we want to make sure we do is we either can wrap it up in a moist 2x2. If we don't have any milk, it says preserve in fresh whole milk. Obviously, we don't carry that in the back of the medic or anywhere on our truck. However, if you are at somebody's house or you do have access, that's the better option, is to put it in like a cup of milk because of the calcium. And then, once again, most of the time what we're going to find for ourselves is going to be just a tooth, and we end up just moistening up a 2x2 or a 4x4, wrap the tooth in that, make sure you obviously don't lose it, and then take that to the hospital so they can reimplant it. So nasal injuries, this is a variety of mechanisms, including the blunt or penetrating trauma. So the most common injury is epistaxis, and for children's foreign bodies. Believe it or not, I've probably had more kids with like Legos and everything else up their nose than I've had delivering babies. It's just it's something that kids seem to do. I'm not sure why. My son did the exact same thing. He come to me one day crying. I couldn't figure out what was wrong. And I finally figured out that he had a little something yellow sticking out of his nose. It wasn't hard to get out. I was able just to pop it out, but it's very very uncomfortable. And unfortunately, if it's too far back, we're not going to be able to do anything with it. So nasal bones between the eyes, nasal cartilage provides shape to the nose, and then we worry about the septum, the turbinates, and the sinuses. So for us, when we're doing nasotracheal intubation, so we're nasally intubating somebody, the septum, the turbinates, and the sinuses are all very important to us. The septum because we need to make sure that they don't have a deviated septum that can cause problems. Turbinates, we can rip every one of those out as we're doing nasal intubation, which that's what causes all that bleeding. And then the sinuses, making sure that you're using a proper technique, because it's not uncommon or it's not hard to end up missing and then putting the tube into the sinuses. So epistaxis, anterior bleeding from the septum, usually venous. Posterior bleeding is often drains the airway, and it may be associated with basilar skull fracture. So now just a little tidbit for trauma. It may work with trauma. However, it doesn't always work with trauma, but most of the time, it was a trick that one of mine and my wife's friends taught us, who's an ENT. If you have somebody with a bloody nose, instead of just holding pressure and then trying to take it off, is the first thing you should do is have them blow their nose. When you get there, have them blow their nose. A lot of times that'll blow the clot out. Pinch their nose, hold it for a minute or two, let go, have them blow their nose again, pinch their nose for a minute or two, and then see if the bleeding has stopped. A lot of times they've built a clot up, they've got posterior bleeding, they've got bleeding behind that, so all that blood is going down to their airway and it's coming out of their nose, and that's what, they think, gee, I've got, got all this bleeding, I can't get it stopped. So first thing, have them blow their nose. Second thing, pinch their nose for a minute or two, and this is their nostrils, not the bridge of their nose. Pinch their nostrils for a minute or two, then have them blow their nose again, pinch their nostrils for a minute or two, and if the bleeding is not stopped, they definitely need to go to the hospital. For a trauma patient that has a bloody nose, there's no doubt they need to go to the hospital because it's caused enough injury to their nose, and they could have underlying problems. Once again, it could be associated with a basilar skull fracture. All right, just a quick little cartoon. It says, often looks worse than it is. Low patient's direct pressure work wonders. All right, so for kids, variety of objects of foreign bodies, they'll have food or toys. It says all can be left alone or removed later. So you don't always have to remove it. If it's something that you can visually see and you can actually get a hold of it, by all means, remove it. However, if it's not causing any kind of obstruction or it's deep enough to where you cannot grab it, then do not attempt it. Just take them to the hospital because they have special pliers or they have special forceps that they can get it out with. So nasal injury management, once again, direct pressure, this is over the septum. I will tell you that it's a lot better to pinch their nostrils as opposed to their septum. Upright position, leaning forward or in a lateral recovered position. And then if you have any kind of cerebral spinal fluid present, do not apply direct pressure and just allow it to drain because you don't want that building up pressure because that in turn can increase the intracranial pressure. And you don't want to increase the intracranial pressure in a patient. All right, so neck trauma, for us, things we need to worry about. Remember, there are 3 zones. Zone number 1 is the sternal notch to the top of the clavicles, and that has the highest mortality. Zone 2 is the clavicles of the cricoid cartilage to the angle of the mandible. That contains most of the major vasculature in the airway. And above the angle of the mandible, so you got the distal carotids and the salivary, and then the pharynx. So transected trachea, so the larynx separated from the trachea are fractured. So have vocal cord swelling, altered airway landmarks, and soft tissue edema. So this can be from a karate chop, a punch, a baseball bat, any object hitting them, a steering wheel, an airbag, number of different things that can transect the trachea. Vessels lacerated or torn, so we've got severe bleeding or large vessels, airway compromise, and a risk of air emboli, hypoxia, or ischemia. Some of the things we need to look for is a pale or cyanotic face, obvious external injuries, a frothy blood or sputum from the wound, subcutaneous air, so kind of push along if you feel like they describe it as Rice Krispies. To me, it's just like kind of a bubbling. Once you feel it, you'll always know it, but it's that sub-Q air underneath the skin. A voice change. Now they're hoarse or they're not talking at all, but they're trying to talk. They just have no voice. Feeling of fullness in their throat, and then the signs of a stroke with an air emboli. So if they start having signs of a stroke and they've taken a chop to the neck, they possibly could have had air emboli, and now it's actually causing a stroke. So esophageal injuries, this is especially common in penetrating trauma. Signs and symptoms may include subcutaneous emphysema, neck hematoma, and a posterior nasopharynx. Has a very high mortality rate from the mediastinal infection, secondary to the gastric reflux through the perforation. So the stomach contents come back up through the perforation, and then they end up getting severely infected, and then they just can't fight that. They can't give them enough antibiotics to counteract that. So we need to consider a semi-Fowler's position, and then versus supine position, unless it's contraindicated by the mechanism of injury. So semi-Fowler obviously is sitting up, or high Fowlers would be sitting all the way up. Semi-Fowlers would be reclined just a little bit. So that's a possibility. Once again, the position would make sense just because if you have somebody that has a airway compromise, you lay them down, then their airway compromise could get worse. So just it's patient by patient, but you definitely want to consider a semi-Fowler's position for these patients. So things for us that we need to worry about, we need to make sure we suction them. Once again, if they're able to hold a yonkers, let them suction themselves. If they can't tolerate holding the yonkers, they can't follow commands, or they're unconscious, by all means, take somebody with you to suction, suction, suction. Make sure you intubate early. Laryngeal edema is something that may not be, edematous right now, that could, by the time you get to the hospital, definitely cause that. Remember, we're an extension of the hospital, so if you have to, you want to intubate these patients early before they end up getting laryngeal edema, and that laryngeal edema ends up closing off their airway, and then now they're going to end up getting a surgical crike. It says it may require a cricothyrotomy, so if you're not able to get them intubated, or they already have enough significant damage, a transected larynx or a transected trachea, then you need to make sure that you use a cricothyrotomy or the needle crike or the quick trach. Stop bleeding as best as possible. It says occlude large blood vessels quickly. The left lateral position with occlusive dressing to the wound. Consider spinal motion restriction, stabilizing impaled objects, and then you want to make sure you transport them to a trauma center. Alright, so a couple things on cranial nerves. It says it may not be helpful in an unconscious patient, but if they happen to wake up, remember cranial nerve number 1, they'll have a loss of smell or taste, which in turn it could be a basic skull fracture hallmark. Cranial nerve number 2, they'll have blindness or visual deficits. Cranial nerve number 3, ipsilateral or dilated fixed pupil, so one-sided. Cranial nerve number 7, they'll have immediate or delayed facial paralysis, basilar skull fracture or a LeFort fracture. Then cranial nerve number 8 is the deafness, so basilar skull fracture there. So here's a picture of the cranial nerves. So you can see that the cranial nerve number 12, so the hypoglossal. Here's cranial nerve number 11, accessory or the trapezius muscles, the vagus nerve, which is number 10, glossopharyngeal, number 9. Here's the one we were talking about with number 8 with the deafness, the cochlear, the vestibular. Number 7 is a facial. Once again, that has to do with, you can have basilar skull fractures, and also that's the one that we worry about for Bell's palsy. So the trigeminal is number 5. So facial, sinus, and teeth. Number 6 is the lateral rectus muscles. Trochlear, the superior oblique muscle. Oculomotor is number 3. 2 is the optic, and then 1 is the breathing or the sense of smell. Okay, that's going to be the end of the presentation for the facial injuries or the maxillofacial, ophthalmic, and dental trauma for the 2014 paramedic refresher for fire and rescue.